Good evening, everybody. I am delighted to welcome you to the 2020 Sir Roger Jowell Memorial Lecture. My name is Alison Park and I'm welcoming you on behalf of the organising committee. This is the 7th in this series of lectures which take place every year in Roger's memory. They're planned by a very small committee drawn from organisations with whom Roger was very closely associated, including NatCen, the European Social Survey at City University, and the Social Research Association. I'd like to thank my fellow members of the committee, as well as our chair for this evening, Caroline Costongs, and of course our speaker, Sir Michael Marmot. In a moment, I will hand over to Caroline, but first I would like to briefly introduce her. Caroline has been director of EuroHealthNet, the European Partnership for Improving Health Equity and Wellbeing, since 2014. And given the subject of tonight's lecture and Roger's keen interest in European and cross-national research, Caroline seemed a very obvious choice of chair to us for tonight's event. So I will now hand over to Caroline. Over to you.
Thanks a lot, Alison. Also on my behalf, I would like to welcome all of you to the 7th Memorial Lecture of Sir Roger Jowell. And as Alison mentioned, EuroHealthNet is a partnership of national public health institutes, regional health authorities, and several research institutes. And our main aim is to reduce health inequalities in Europe. And we do that mainly through advocacy and working with policymakers. So we are based in Brussels and have a lot of contact with European Union institutions, European Commission, but also with the WHO and with policymakers in member states. And we use a lot social sciences and socioeconomic data to inform policymakers on the root causes of ill health and disease. And I'm therefore truly honored to be able to chair this memorial lecture, because Sir Roger Jowell, I think he was one of the top social scientists in Britain. And I learned also a very kind and nice man, able to really make things happen. He built the foundations for the NatCen Social Research and the Centre for Comparative Surveys at City, the University of London. And as you must know, he played the leading roles in setting up social surveys in the UK, like the British Social Attitudes and the British Election Study. He also contributed to more robust comparative data and research, for example, through setting up the European Social Survey. I also noted that Sir Roger Jowell was very much recognizing the value of qualitative research too. So why it is, how people think or behave as they do. And he established a qualitative research unit at the SCPR. And he also coordinated the first deliberative polling in Britain involving focus groups, which I like to hear. So this memorial lecture will for the first time be held online, as we all know why, due to the COVID-19 pandemic. And I wonder how Sir Roger Jowell has thought about the pandemic and looked at the pandemic, because we see that COVID-19 has been painfully exposing the existing inequalities in our societies in the UK, but across all over Europe. And the pandemic gives the heaviest impact on people that are already suffering deprivation or are more on the bottom end of the social gradient. They are far more vulnerable to the infection, and if they get COVID-19, they often have more severe forms of the disease. So there's a real risk of widening health inequalities, not only due to the direct impact of the virus and the disease, but also due to the mitigation measures and also the long-term prospects in terms of a potential recession and so on. So health equity and social justice is a very timely topic, I think, of this 7th Sir Roger Jowell Memorial Lecture. And I'm therefore delighted to introduce to you Professor Sir Michael Marmot. He is the director of the Institute for Health Equity at UCL, and he will talk about the various strategies there are to tackle global health inequalities. So Michael Marmot is also a source of inspiration to me personally. As you know, he has been professor of epidemiology at UCL since 1985. He is the author of several books like The Health Gap, and another one is called The Status Syndrome. I mean, if you look at his biography, it's pretty impressive. But I wanted to highlight one of the activities that actually affected my professional life and maybe also the course of EuroHealthNet. And that was his role as a chair of the WHO Commission on Social Determinants of Health, because he produced a really powerful report that was called Closing the Gap in a Generation in August 2008. As a follow-up, he also conducted a strategic review of health inequalities in England in 2010 on request of the government. And this was followed up by a European review for the European Commission, and also one for WHO Europe in 2014. And then Michael later updated the 2010 England report actually early this year, and just before the coronavirus hit us all, he managed to launch his report that was called 2020 Health Equity in England, the Marmot Review 10 years on. Also importantly, Sir Michael was a very good friend of Sir Roger Jowell. And knowing that the European Social Survey was an important legacy of Sir Roger Jowell, and also knowing that, for example, the European Social Survey is really key to understand the social determinants of health in Europe, I can already say that the two men must have had a lot in common, but I will leave it up to Michael Marmot to talk about it himself. So I'm delighted to give Michael Marmot the platform. But just before he starts, I would like to remind you that you can ask questions by using the Q&A function. I will be reading your questions and try to bring them together, and we will have the opportunity to ask Michael the questions after his lecture. So thanks for this, and enjoy the lecture. And Michael, I would like to hand over to you. Thank you.
Thank you. Thank you, Carolyn. And it is an absolute pleasure to give the Roger Jowell Lecture. As you said, Roger was a good friend. I think he looked a bit like the picture on the right when I first met him, and a bit like the picture on the left when last I saw him. But this is how I remember him. In fact, Roger and his wife, Sharon Witherspoon, and my wife and I spent a lot of time together. We went on a brief holiday in Italy, and that's Roger, an adoring Sharon and a Roger holding forth. I remember once playing tennis with Roger, my son, who was about 10 years old, and one of Roger's sons, and we're playing doubles. And because Roger was limited by his ill health, he would always try and hit winners. And sometimes they would work and sometimes they wouldn't. And my little son watched as these balls whizzed past his ear, sometimes going out, sometimes going in. And he said, "Roger's a bit erotic on the tennis court." And when I reported this to Roger, he was delighted at the idea that he might be erotic on the tennis court. Some of us might have thought erratic, but never mind. And Roger said to me one day, "Why don't we put in a bid for the health survey for England? Do it as a partnership between UCL and the National Centre for Social Research, or SCPR as it was." I said, "Well, it's not quite the sort of thing we do. We're only interested in research, not routine surveys. Maybe if we could turn it into a longitudinal study, that would be something." Well, the Department of Health said, "No, you can't." And Roger said, "We will, just wait." So we launched the Health Survey for England, still going on. The authors are NatCen and UCL. But then the question was, well, could we turn it into a longitudinal study? And enter Richard Sussman, who was the associate director of the National Institute of Aging in Washington, and NIA had been supporting my research on the Whitehall 2 study. And Richard Sussman contacted Roger and me and said, I'm coming to London. I'd like to talk to the two of you. Would it be possible to set up a longitudinal study of aging in England? And we said, yeah, we could base it on the Health Survey for England. So Richard said, well, I'll be in London next Thursday. Could we meet Thursday evening? The problem was, I was a member of the Royal Commission on Environmental Pollution, and we met the first Thursday and Friday of each month. That was okay. But the worst part of being on the commission is we had to dine at one of the members' clubs the Thursday night. I thought I'd get thrown off the commission because I didn't have a club. When it was my turn, we dined at the Royal College of Physicians. But that Thursday, the Earl of Selborne was hosting us at Brooks's. Now, you probably don't know about these things, but if you have to ask where is Brooks's, you shouldn't be going there because it's in St. James's, but it doesn't have a sign outside or a number. And somehow you've got to find your way into it. Well, Richard Sussman found his way. So Richard, Roger, and I met in Brooks's. And the butler came and said, would you like a drink? And I panicked. I thought, what do I do? If we order a drink, it might go on Lord Selborne's bill, and then I wouldn't know how to reimburse him. And I said, sorry, chaps, no drinks. We've got to remain thirsty. Well, it was a quick meeting, and that gave rise to ELSA, the English Longitudinal Study of Aging. So Roger was right. Just hang in there. We'll do the Health Survey for England, and there will be the possibility to turn it into a longitudinal study. And in relation to Carolyn's question, what would Roger have made of COVID-19? I think he would have made two things of it. The first, and it's the theme of my lecture this evening, is that the pandemic exposes the underlying inequalities in society and amplifies them. And the second is Roger would have had NatCen very much involved in charting the impact of the epidemic and of the lockdown. And that is the theme of my lecture tonight. As Carolyn said, I chaired the WHO Commission on Social Determinants of Health. We did the Marmot Review in England, we did the European Review, and just under a year ago, I chaired and we reported the Commission of the Pan American Health Organization on Equity and Health Inequalities in the Americas, Just Societies, Health Equity and Dignified Lives. And that was before the pandemic. And what we said then is of even greater relevance now. We said at the beginning, quoting Nelson Mandela, overcoming poverty is not a gesture of charity. It is an act of justice. It is the protection of fundamental human rights, the right to dignity and a decent life. And the conceptual framework of the Commission, similar to our previous commissions, structural drivers, political, social, cultural, and economic structures, the natural environment, land and climate change, and colonialism and structural racism. And those in turn affect the conditions of daily life. So we had 3 recommendations there, 7 there, and 2 more related to taking action, governance and human rights. And our approach was one of intersectionality, looking at social and economic inequities, gender, sexuality, ethnicity, disability, and migration. And the outcome was health equity and dignified lives. I will talk about the Marmot review 10 years on, and in that context, COVID. But I just want to take a global perspective for a moment. This is from the United Nations Development Program. The Human Development Report people did a special report on COVID-19. And if you look globally at causes of death, there's transport injuries, HIV/AIDS, self-harm, malaria, and COVID-19. Wow, absolutely dramatic in its impact on the global burden of disease. The Human Development Report reports regularly on a Human Development Index, which is, as you probably know, a combination of life expectancy, education and learning, and economic fortunes, gross national income. And this is the Human Development Index globally. You can see it varies a little bit year on year. 2008 was the global financial crisis, and it did have an impact on the Human Development Index, but quickly recovered. And this is the projected effect of the COVID-19 pandemic. Absolutely dramatic in its effect on Human Development Index, much, much bigger than that of the global financial crisis. And they give the example of how an external shock exposes inequalities in society. This is Hurricane Maria in Puerto Rico and the effect on mortality, excess deaths in the lowest socioeconomic group, the medium socioeconomic group, and the highest. So an external shock like a hurricane exposes and amplifies inequalities in society. And the pandemic is doing the same thing. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. The healthcare system and healthcare workers have been absolutely vital when it comes to the pandemic and COVID-19. But I'm not going to talk about the healthcare system. I want to talk about the conditions that make people sick. And as Carolyn said, on the 25th of February, just before the pandemic crashed upon us, my colleagues and I produced Health Equity in England, the Marmot Review 10 years on. So I had looked at health inequalities in England. We published our report in February 2010. And on the 10-year anniversary, we looked back and said, what's happened in the last 10 years? And my summary is we have lost a decade, and it shows. If you look at life expectancy at birth, life expectancy, and this goes back to 1980, was increasing about 1 year every 4 years for women and for men. If I took this graph all the way back to 1890, for more than 100 years, life expectancy was improving about 1 year every 4 years. And then in 2010-11, there was a dramatic break in the curve. And the life expectancy increase just about ground to a halt. What happened in 2010? Well, there was a change of government, a conservative-led coalition government. Government's a bit sensitive. Could anything they did possibly lead to this? An important question. Before we get to that, one question when we reported on the slowdown in life expectancy was, well, surely it has to slow sometime. It can't keep going on forever. So we looked at what had happened in other countries. This is the annual life expectancy improvement in weeks for all of these different countries. And there's the UK. It was the slowest of all except Iceland and the United States. Now that's very important because as we were coming into the pandemic, health had more or less stopped improving in England. So then when we look at what happened during the time of the pandemic, this is excess deaths. As you know, there's some problems in comparing COVID-19 mortality among countries because of differences in the way cause of death is assigned. So the Office for National Statistics produced figures on excess deaths. And I took this graph from The Economist. It's a better graph than ONS's graph. Excess deaths is looking at the prediction from the previous 5 years. How many deaths would we expect in this week of 2020 if the rates of the previous 5 years applied? And then we look at the excess. England had a bigger excess than Scotland and Wales and Northern Ireland. And in fact, England had the biggest excess of any country in Europe. There's a lot about the US's mishandling of the pandemic, and indeed, the US's mishandling of the pandemic has been catastrophic, and our excess mortality is higher than in the United States. So I'm making a link between the fact that the slowdown in life expectancy improvement was more marked than in any other country except Iceland and the US, any other big country, and our excess mortality during the pandemic was bigger than in any other European country. And then there's the question of inequality. Poor people, these are deciles of deprivation by area. Poor people have shorter life expectancy than everybody else. But I've been emphasizing for a very long time that inequalities in health are not confined to poor health for the poor, but it's a social gradient. The least deprived have high life expectancy, and it's a graded relation in between. The gap between least and most deprived for females was 7.7 years, 9.5 years for males, and the gap's getting bigger. The gradient got steeper. Inequalities are getting bigger. And then if we look at regions, this is women. If you look at women in the least deprived decile, there's not much regional difference, and life expectancy was improving for most regions. In other words, if you're rich, it doesn't much matter where in the country you live. If you're poor, if you're in the most deprived, it matters enormously. If you're a woman in London, in the bottom 10%, life expectancy improved. Pretty well everywhere outside London, life expectancy went down. So just to recap, coming into the pandemic, when we reported in February, life expectancy had stopped improving, inequalities were getting bigger, and life expectancy for women in the poorest 10% outside London was going down. Things were getting worse. And they're not supposed to happen like that. We expect health to keep improving year on year. And so it had for 100 years, and then slowed down dramatically in 2010. Now, let's look at COVID-19. In England, the gray is all-cause mortality. There's the familiar social gradient, which I've just been describing. And the blue is COVID-19, a very similar social gradient. I'll come back to this excess in a moment. But what it means is that if you see the same social gradient for all cause and for COVID-19, it's likely that there's a common set of causes of inequalities in COVID-19 to inequalities in health more generally. Why this excess at the bottom? It could be employment in frontline occupations, living in overcrowded, multi-generational households could be playing a role. And we see a similar phenomenon in Scotland. There's the social gradient for all causes, and there's the social gradient for COVID-19. The difference between top and bottom is 1.9 times for all causes, 2.3 times for COVID-19, but a very similar gradient with some excess down the bottom. When we look at Black, Asian, and minority ethnic groups, look at women first, big excess in Black, British. When adjusting for a variety of factors, crucially among them deprivation, about 2/3 of that excess can be accounted for by deprivation, and a bit more than half in the men. Bangladeshi or Pakistani, big excess, but most of it can be attributed to deprivation. When ONS published these figures, I was on the BBC. A health minister was asked what he thought about this, and he said, it's terrible. He's very concerned, and Black British people should wash their hands and practice social distancing. And I was asked, what did I think? And I said, good idea, but we should also deal with structural racism. In my 2010 review, we had 6 domains of recommendations. Give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4 was crucial, a healthy standard of living for all, healthy and sustainable places and communities, and taking a social determinants approach to prevention. And we focused in the 2020 review very much on the first 5 of those. When the government came in, was elected in 2010, they presented to us austerity as if it was a moral imperative. And they said, we will reduce public expenditure. And they did. In 2009-10, public expenditure was 42% of GDP, and they brought it down to 35%. That's huge. We went from being in the middle of European countries to being at the bottom end in terms of public expenditure. And it was done in a most regressive way. This is council spending per person. Look at the dark gray. This is total local authority service spending per person. These are figures from the Institute for Fiscal Studies. In the least deprived 20% of areas, total spending went down by 16%. And then the more deprived the local area, the greater the reduction. So in the most deprived 20%, spending went down by 32%. I showed this graph to an economist from the World Health Organization, and she said, you must have made that up. I've never seen anything quite so neatly regressive. The greater the need, the greater the reduction in spending. Did these policies of austerity work? Well, not really. If the purpose was not simply to roll back the state, but somehow get economic growth, it didn't work. This is wage growth in the UK from 2007 to 2018. It was negative. The only slower countries among the big OECD countries were Mexico and Greece. And then all other countries had positive growth. So it didn't work in its own terms, and it may well have done damage to the health of the population and to inequalities in health. I'm not going to go through all of my recommendations and all our findings, but let's look at childhood, children living in poverty before and after housing costs. In 2010-11, and poverty is defined as less than 60% median income. In 2010, about 18% of children were in poverty After housing costs, that was 27%. And that went up so that the 27% became 30% by 2017-18. I'll come back to housing because housing, I've argued that housing is a food issue because if you can't afford rent, how do you eat healthily? And when we look at type of family, this is a lone parent not working. In 2010-11, 61% of children were in poverty if they were growing up in a house headed by a lone parent not working, and that went up to 70%. Work was supposed to be the way out of poverty. So let's look at a lone parent in full-time work. 18% of children were in poverty in 2010, and that went up to 30% by 2017-18. What about taxes and benefits? Again, this is from the Institute for Fiscal Studies, IFS. Let's look at working age families with children. This is the long-run impact of planned tax and benefit reforms by income decile. So those in the poorest 10% would get a slightly greater than 15% reduction in their income as a result of the Chancellor's changes to the tax and benefit system. In the second poorest decile, 12%, then 9%, and the richer you were, the less the reduction. I showed this graph to a former government minister and said, your government's policy was to make poor people poorer. And he looked a bit uncomfortable and he said, well, maybe it wasn't our explicit policy. My response is they're very clever people in the Treasury. They must have told you that that would be the effect of those policies. And then we look at COVID-19, lockdown. This is from the Food Foundation. Food insecurity in households with children has nearly doubled. And then insecurity due to supply issues. 2 million children during the pandemic are food insecure. So, as I said, we've got to put together income, food, and housing because they all have a draw on the household budget. And if you're spending more on one, you can only spend less on something else. I was asked by The Lancet, of all things, to go and review a photo exhibition in London. And it was bedrooms of London. The background is to illustrate before housing costs, 17% of children were in poverty. After housing costs, 37%. And in this exhibition, there were these remarkable photos of what it was like for children growing up in households in London. Emily, Martin, their babies, sleep on the sofa bed in the living room where they eat. The other 3 children in the bedroom. Martin earns £800 a month. Outside, older kids compete for drug clientele. They leave knives in the bushes where younger children play hide and seek. So he's earning, but that's all they can afford. 2 bunk beds, 4 children sleeping in one bedroom, 3 teenagers, a 9-year-old in one room, mum and dad in the other. Both parents work, but they still have to have their rent subsidized. And the mother says, the area is full of gangs. I want my children to live in a safe place. There are kids around the building who don't go to school. I call this one everything and the kitchen sink. A mother and her baby living in this one room. There's the kitchen sink, there's the door, that's it. Emily's partner left her when she was 5 months pregnant. She said, Emily said, at the beginning, I didn't have benefits, so I didn't have food. I was crying for no reason, for no reason. Emily puts a towel under the door to stop the weed smoke from getting in. A Nigerian mother, an English father, and 3 children in a 2-bedroom flat. And the mother says, to know that somebody somewhere is making something available for you to be happy. My feeling welcome in this country has been all through charities. I've been arguing that the health of a population tells us something fundamental about the nature of this society. And the fact that our health has stopped improving and our inequalities are getting bigger tells us something important, that our society has stopped improving and inequalities in society are getting bigger. And this Nigerian mother is testament to that. And the rhetoric of the last decade was to rediscover the language of the undeserving poor. Are these people living in these bedrooms feckless? Are they choosing the easy life of welfare dependence? As one mother said, nobody falls into this on purpose because your whole life is going to be a trap. And then you will see yourself living a life you never thought you would. We've been concerned with education and the impact of lockdown on amplifying the inequalities. This was from the National Foundation of Education Research, looking at the least deprived schools and the most deprived, and asking teachers about how much learning loss there was in their pupils. Not behind at all, 3%, 24% in the least deprived said they're 1 month behind, 32% said 2 months behind. Look at the other end. In the most deprived schools, there you find the children 6 months, 5 months, 4 months behind. So the educational inequalities are being amplified by lockdown. By not getting control of the pandemic when we should have, we are amplifying inequalities. And to come back to the Human Development Report, the Human Development Index, countries at high Human Development Index can indulge in more direct spending during COVID-19 and more loans and guarantees. So the international inequalities will be expanded as well. Last week, there was a publication of the Social Progress Index. It's got 16 indicators. And I was quite interested. I looked at that and thought, the USA and Brazil have handled the pandemic extremely badly. I wonder how they were doing on social progress compared with Germany, which handled the pandemic rather well. Well, I took 2 indicators of the 16, inclusiveness, so there's Germany, stayed pretty much the same, slight increase. There's the USA. As somebody perhaps could tell me afterwards what happened between 2016 and 2017. Something must have happened in the US, maybe on January the 20th, 2017, that inclusiveness went down. And Brazil, that had their own version of that nightmare, inclusiveness went down dramatically. If we look at personal safety, Germany, high and stayed high. The US dramatically went down in 2017, and Brazil was lower and a slow further decline. Now, this is not even correlation, let alone causation, but it is interesting that a country like Germany that handled the pandemic well scored more highly on social progress than these 2 countries that handled it badly. If you're asking, the UK was somewhere between Germany and the US. In my 2020 report, we looked at air pollution, among other things, and showed that the most deprived quintile had greater exposure to PM10 than the least deprived quintile in London, Liverpool, Birmingham, Bristol, Leeds, and Sheffield. One more indignity of being in a more deprived area is you get greater exposure to air pollution. And the reason I show that now is we wanted to put climate change and health equity together. So we, for example, recommended that 100% of new housing should be carbon neutral by 2030, with an increased proportion being either affordable or in the social housing sector, and aim for net zero greenhouse gas emissions by 2030, ensuring inequalities do not widen as a result. As we think about building back better, we need to put sustainability, tackling the climate crisis, and health equity together. I was invited to Australia by the ABC, the Australian version of the BBC, to give lectures, Boyer lectures, which are the ABC version of the Reith lectures, although they wouldn't like my saying that. And I talked about inequalities, including among Aboriginal people, Aboriginal and Torres Strait Islanders. And to advertise my lectures, I was on the ABC's Q&A, which is the ABC version of Question Time, although they wouldn't like my saying that. And one of the things I talked about was about redistribution of income, how there was a lot of money sloshing about and we could use it to solve a lot of the world's problems. And one of the other panelists said, "You're in fantasy land, mate. You're in complete fantasy land. That's never going to happen." Well, the next day I went to an Aboriginal community controlled health center and I was greeted with a sign, "Welcome to Fantasyland." I would say to the people listening to this tonight, I want to welcome you into my fantasy land. And in my fantasy land, we are going to create a fairer society, a fairer, sustainable society with better health for everybody. Thank you.
Thanks a lot, Professor Michael Marmot, for your inspiring lecture, as always. I thought that you said, like the health of population says something about the health of a nation. And I think that's indeed very much the case. I have a few questions that are put in the Q&A. And maybe I will give all four of them to you, Michael, so you can start thinking a little bit. So one is about the social gradient and mental health. So whether we see that social gradient and inequality in mobility and also in access to services. So one is on mental health. Another question is about the indicators used for the categorization of deprivation. So what is used there? On what basis are these categories formed? The third question is about the regional differences. So why do you think that poor women in London do better than poor women elsewhere in the UK? So how come? Why is that? And the last question so far is, who cares further about health inequalities apart from us, the 229 people that are now listening, and obviously people of concern, because it seems that government as well as media are not sufficiently putting attention towards it. So these four questions first to start with, Michael.
Yeah, so firstly, the social gradient in mental health. I've been arguing that people who are concerned with social determinants of health have to be concerned with mental health. It is 1 in 4 people have some kind of mental illness in our society, and we need to be concerned. It's a major cause of morbidity. People with mental illness have shorter life expectancy by 10 years or more. So it's both a cause of suffering, the mental illness itself, and it's a predictor of shorter lives, physical ill health as well. And half of it has its onset by age 14, which means that the early life agenda is absolutely crucial for mental health. And that means that lockdown should alert us to the concern of what's happening to children in lockdown, because that's likely to make the gradient steeper. Because children in better off families, particularly access to computers, learning, their own space, and so on, as distinct from being crowded, no privacy, no access to computers, no access to green space, and the like. And I've been arguing that people who are concerned with mental illness have to be concerned with social determinants of health. So we need to come together. And there are encouraging signs that both sides are starting to recognize that importance. My colleague, Jonathan Campion, has produced a comprehensive account of the evidence on social determinants of mental illness and what you can do to change it. So there's much you can do based on the evidence. The second, the indicators of deprivation. This is ONS's standard index of multiple deprivation, and it's a combination of social, economic indicators. Sometimes it includes health, which is the danger of autocorrelation, but if you remove health out of it, it doesn't change the link between deprivation and ill health. We use it because it's available and you can update it on a regular basis, but in surveys, you can look at income, you can look at wealth, you can look at years of education, and you see the same social gradients. Now, they're not all the same. It's quite important to distinguish, for example, between wealth and income. They're telling us different things, and education. But the social gradient's not reliant on using the index of multiple deprivation. The question of why the deprived women in London are doing better, the easy answer is, I don't know. What we see, it's not just that I showed you for shorthand, the deprived, the women in the bottom decile, but what we see is the social gradient is steeper outside London than it is in London. So the more deprived you are, the bigger the disadvantage of living in the northeast or the northwest than in London or the southeast. And having said, I don't know, it may well relate to the structure of opportunity. In the end, there have been more jobs, more opportunities in London than there have been in the northeast and the northwest. And it seems to be worse to be deprived in those areas. But that's not, to me, a satisfactory answer. I don't understand it well enough, but it is important to look at it further. The question of who cares? We do. One of the points of the gradient is that if it were only related, if health inequalities were only related to them, the poor, we could say, well, who cares? I hope we wouldn't say that. But it's related to all of us below the very top. We'd all like to have health as good as those at the top, and the country as a whole is not doing very well. We've got life expectancy 4 years shorter than in Japan and Hong Kong. We're really not doing very well as a country. So even the people at the top aren't doing so well. And I think it's related to the same set of causes that relate to health inequalities. So even if you had not an ounce of altruism in you, even if you said, I don't care about people who are not like me, I hope you wouldn't say that, but even if you did, you're involved because you and I are affected by this social gradient. So we should all care. But the real reason we should all care is not just self-interest, but because we want to live in a better society. And a society marked by these inequalities is not such a good society to live in.
Thanks a lot, Michael. I see many questions are coming in, so I hope we'll be able to address with them all. I have a new set of 4 questions for you, Marmot. One is on structural racism. If you can talk a bit more about that, and particularly what one thing would you recommend to tackle structural racism? And another viewer asked this in relation to NHS and whether a right-based approach may work towards doctors, but what do you then do if you see a doctor or staff are, let's say, misbehaving? So around structural racism. Another more broad question is about the SDGs, whether you think that's truly helpful to further drive this agenda, or is it only of interest to statisticians? Then a question around universal basic income, whether you believe there's future in that kind of measures. And a 4th one, I'm sorry, they're all quite different. The 4th one is, would you say that public health priorities will change due to COVID at the local level for local authorities? Because a lot of the money is ring-fenced. And yeah, would you think that COVID would change public health priorities at the local level?
Excellent questions. For my second lecture this evening, I will approach these 4 questions, and I'll come back to you in 45 minutes' time. So structural racism, I think the first thing to say about it is we've got to be aware of it. And I think we were able to delude ourselves in Britain for a long time that it didn't exist. Racism was a US problem, a South African problem, some other problem, but not our problem. We were nice, caring people, and we are nice, caring people. But we do have a problem of racism, and we've got to acknowledge it. I was asked on the BBC, well, what do you mean by structural racism? So I said, well, let's look at Minneapolis, where George Floyd was murdered. Something like 70% of white people own their own home, 25% of Black people own their own home. The income of Blacks versus whites is about 60%. And that's gone on for a very long time, about 60%. And it's structural. Then you look at arrest rates, the police. The police kill about 1,000 people a year in the United States. 30% of them are African American, whereas in the general population, it's 13%. So the police kill too many people, and a lot of the people they kill are white, but 30% of the people they kill are Black, and only 13% of the population. So that's structural racism. And if we come back to the UK, happily, our police don't often kill people, but they do stop and search. And that's overwhelmingly more likely if you're Black than white. Economically, at disadvantage. Educationally, at disadvantage. And the question got raised when it was apparent that Black, Asian, and minority ethnic groups working in the NHS had particularly high mortality from COVID-19. And the BMA, the British Medical Association, raised the question of whether that was in some way related to discrimination on the basis of belonging to ethnic group. As to what you should do if you see a colleague behaving badly, well, I'm not wise enough to be able to tell people what to do. But I do think we all need to stand up for less racism in society. Exactly the right way to go about it. It's different from structural racism is not the same as an individual being prejudiced. Yes, individuals can be prejudiced, and that's bad, but we need to deal with the structural issues that are leading to disadvantage. Are the SDGs helpful? Maybe, Carolyn, people like you and I have spent a bit too long in talking to politicians and WHO and the European Commission and the like. But in those circles, the SDGs are very helpful because countries have signed up to them. They've actually committed. Now, the fact that a country's committed to something, as we discovered in Britain this last week, the fact that they committed in law to something doesn't seem to be any barrier to doing something different. But we'd like to think that if a country committed to the SDGs, they'd be more likely to act. And conceptually, putting together sustainability and equity as they do, of the 17 SDGs, at least 11, I would say, are social determinants of health. Then there's the health one. So for me, the SDGs are extremely helpful because it's a way of saying to countries, you signed up to these, right? Now let's do something. And the simplest thing to do is to start measuring them. Taking action's a bit harder, but measuring them so you can monitor your action. UBI, very important, universal basic income. There is a debate, I don't know how vigorous the debate is, between universal basic income on the one hand and universal basic services on the other. What we saw with the furlough scheme in Britain was essentially the government overnight instituting universal basic income for 9 million people. We'll pay your salary. There you are, done it, or we'll pay 80% of it. Now, if you are close to the poverty margin, getting 80% of your salary is not great, but it's better than getting nothing. It was a form of universal basic income. The other side of it is rather than give people income and then let them compete in the marketplace for what they can get with that money, is universal basic services. I talked about the problems of food. 2 million children, food insecure. We know that before COVID-19 and the lockdown, there were 1 million families resorting to food banks. Food, education, the NHS, housing, transport, communications, these are basic services. And you could make a good argument that it's something, one way or another, the society should be able to provide. Then, if you have a bit of money, you can decide what you want to do with it. You know, do you like to buy shoes or go to football or do this or do that or whatever? But, I mean, we do it with the health service and education. We don't say, here's some money, buy healthcare if you can afford it. We say the state has the responsibility to provide healthcare and education. So there is, I'd like to think, a vigorous intellectual debate as to which would be the better route to go down, universal basic income or universal basic services. And the people on both sides of this debate are terrific people. You know, it's not one of these terrible debates where you've got scoundrels and liars, and it's not that kind of debate. These are good people who are arguing from a good point of view on the two sides of this debate. And will COVID-19 change public health priorities at local level? Oh dear. The Public Health England has just been abolished in the middle of a pandemic. It had its funding cut by somewhere between 20 and 40%. from the time it was established in 2012. And then in the middle of the pandemic, having cut its funding, saying, you're not doing the job very well, we'll give it to a private company overseen by a businesswoman to look after testing and tracing. As somebody tweeted today, if Serco, it's amazing politicians say Serco should be privatized. The private company that's in charge of testing is doing such a terrible job. If it was a public company, they'd say privatize it. In fact, it should be done by public health. But local public health had its budget slashed. So it's neither Public Health England nor local public health have been in a position to respond, and they haven't been given the responsibility to respond. Now, I think it's a job of local public health to organize testing and tracing. Mm-hmm. I would say that it would be tragic if COVID-19 became the excuse to neglect other priorities. Mm-hmm. Absolutely tragic. Mm-hmm. I think my first reaction when I reported that my 2020 report in February and then the pandemic happened was, oh dear, my report will get lost. But it didn't. Once people realized the inequalities dimension, it became ever more important. And it's ever more vital to deal with early child development, to deal with the inequalities in education, to deal with the problems of employment, of having enough money, of housing, of neighborhoods and communities. All absolutely vital. So, yes, there's a real danger, public health. So part of the fact that we were ill prepared for the pandemic is that we cut the public health budgets and the NHS budget had not increased in line with inflation. So we were ill prepared. Yeah, there's a danger about priorities, but we've got to pay attention.
Yes, then there are many more questions, and I should say, Michael, that the majority really liked your lectures and really sending you all sorts of compliments. So nice messages that I'm reading. But people, so I'm grouping now a few questions together because some people say it's such a big problem and it's a bit overwhelming. So for example, staff at schools, they often feel disempowered. And is it what they do? Is that, good enough, and do they make a difference? Or, the role of health professionals and particularly nurses, well, how could they contribute? And young people or students. And the question about what sports can do, because there seems to be more equity in sports, and how can that further contribute. And then a question about then what to prioritize, because you mentioned housing, food, income, pollution. So where to start? So yeah, so it's a complex issue and a bit overwhelming, and how to best respond. And then one question about the role of the European Social Survey. What would you recommend the survey what role it can play? So how to provide further understanding on health inequality. So what should it further do? So your advice there. And a last question for now, and that's whether you expect a further downward trend. Or are you a bit more hopeful and that we're able to sort of reverse this trend in the coming 10 years? Over to you, Michael.
Okay. Thank you. Well, is it overwhelming? And the various aspects to that question. One of the reasons that I've been doing what I've been doing, from the WHO Commission on Social Determinants of Health through the English Review, European, the PAHO reviews, and now the 10 years on, is to try and make it not overwhelming, to try and break it down into things that can be done. Often I get asked, as you asked me now, what about priorities? And is there one thing I would recommend? And I've always avoided that answer. I say, if I thought there was only one thing to do. I would have only made one recommendation. And I don't think it's overwhelming at all. So, for example, in our 2020 report, we're working with Greater Manchester, but what I'm about to report happened at Greater Manchester before we started working with them. In our 2020 report, we had a graph. Children eligible for free school meals, the poorer children, do worse on early child development than the national average. And in Manchester, the children eligible for free school meals were doing worse than the national average for other poor children. Not just than the national average for all children, the national average for other poor children. Wow, that was terrible. And in Manchester, they closed that gap in 3 years. And they're pretty proud of that. They focused on early child development. They said, this is no good. Our poor kids are not ready for school. They can't benefit from the school system. So you might say it's overwhelming. I've talked about income and the tax and benefit system and everything. Well, they focused on this problem. They didn't change everything. They changed the climate for child rearing for those poor kids by investing in services to support children and families. And it made a difference. It's been a busy day today. I was lecturing at UCL this morning, and students, so you asked about students, said, what can we do? And great. So my first, like some boring old person, do well in your studies, sort of was my first thought, do brilliantly. But they want to know, can they do research? Can they get involved? Absolutely. Because this is not just about public health. It's about early childhood. It's about education. It's about employment and working conditions. It's about the macroeconomy, trade relations, the fiscal system, about community development, housing. They're all important. Well, we've got brilliant universities and wonderful young people who work in them, and they want to know how they can get engaged. Now, I think one of the lessons, and you asked about nurses and others, one of the lessons from the pandemic, and I don't know if our politicians have the receptors to receive this lesson, is that society depends on workers in care homes, on drivers, on supermarket checkout personnel, on poorly paid nurses, on all of these people that are kept going. Last time I looked, and forgive me if I've got this slightly wrong, it's the sort of thing Roger Jowell would have known in his fingertips, but last time I looked, the chief executive of a FTSE 100 company, on average, was earning 120 times the living wage, which is 200 times the minimum wage. Half of care workers in care homes are not earning the minimum wage, and 80% are not earning the living wage. Now, on Thursday evenings, when we were all out cheering at the NHS, how many people were cheering for stockbrokers and chief executives of FTSE 100 companies? Wow, terrific. We like what those chief executives are doing for our society. So we recognize what care workers and NHS workers and delivery drivers putting themselves at risk, and bus drivers putting themselves at risk to keep society functioning. But we don't pay them properly. So I think these people who are so important to society, we need to recognize it. We need to, care workers, do they have a profession? They should have. They should be trained properly. They should be paid properly. They should have career advancement. They shouldn't be overwhelmingly migrants paid less than the minimum wage in unstable employment, in temporary contracts. So I think both looking at the circumstances in which these people are working and turning around, having nurses and others be the advocates for doing things differently. And we should seize the moment before we forget how important these people are to our lives, to make that case. The European Social Survey, I heard this evening, and so I was delighted when colleagues in Trondheim in Norway produced a volume on social determinants of health, of papers from the European Social Survey. I heard this evening that module is going to be repeated, which is very pleasing to me. It means that we can document the social determinants of health and variations in social determinants of health across Europe. And echoing a Roger Jowell point, cross-country comparisons are vital. He spent a lot of time dealing with the comparability issue, but we learn an enormous amount from cross-country comparisons. ELSA, that I mentioned at the beginning of my lecture this evening, the English Longitudinal Study of Aging, is part of a collaboration of cross-country work, drawing comparisons. So for the European Social Survey to look at social determinants and health equity across countries in Europe and looking at the variations is really very important. What do I expect will happen? I'm not the first to say that prediction is difficult, especially about the future. And so a Brazilian colleague said to me, I'd been going around the world saying I was an evidence-based optimist. And he said from the depths of his Portuguese, Michael, you're using the language wrong. You're not an optimist. I looked at him, he said, optimists think things are going to get better. You're hopeful. Okay, I'm hopeful. I'm hopeful that the knowledge that we have, the evidence we have, and if we get enough people rallied around the evidence to argue for something different, I'm hopeful that it will make a difference. The politics in countries that I care about, like the UK and the United States, are absolutely dreadful at the moment, but they won't remain dreadful forever. They can't, they don't. History tells us they don't remain dreadful forever. And we who care about health and care about the fair distribution of health and care about our children and care about sustainability have to be part of the argument for building back better. So I'm hopeful.
Mm-hmm. That's good to hear, Michael. Are you ready for a few more questions? And it's also related a little bit to the previous point.
Just about.
Yeah. Okay, yes, because I know it's a lot. It is a set of questions that are indeed moving more towards policy action that we can take. So how can we make ministers listen better? Because some of them seem to be surprised to hear there are such inequalities in COVID-19, if they have already heard about it, but some even haven't noted at all. And how can we bring and build the consensus to bring about change? And what are the policy levers that are there to level up the gradient and achieve this building back better, as you just mentioned? How effective, for example, is the government obesity strategy? I mean, strategies like that, is that sort of effective? Would that work? And then one question about, okay, what reason do policymakers give for not addressing this, because all the evidence is there. So it's political, as you said. And what do they say for not addressing this? So questions around policymakers and policymaking.
Well, how do we make ministers listen better? Again, Roger would have been a better person to answer this question than I. He had more direct dealings with the politicians. I don't know that I know. Carolyn, you and I have had conversations like this before when I get asked, how do you make political change? And my response is, I haven't a clue. I know what I do, which is maybe I'm Don Quixote. What I do is present the evidence in the clearest way I know how. And I present the argument for social justice. Now, if that's naive, if that's Don Quixote, then it's hopeless. But I don't know how to get into smoke-filled rooms and change it any other way. So now, political scientists spend their time doing this. They do seem to know. But I think having the evidence, and whenever you've heard me talk, you've always heard me talk based on the evidence. That's what I do. And I think the evidence speaks for itself. And I said this morning, and I thought about it afterwards, do I have a counter instance? No, I don't think I do. I've never had in Britain a politician say to me in person, you're wrong. I don't believe your evidence. You've got it wrong. Now, maybe I've got a poor memory, and I've no idea what they say when I'm out of the room. They might say all sorts of things. But in other words, I've not had them dispute my evidence. So then the question is, well, okay, if they don't dispute the evidence, why don't they do it? Why don't they do it? Well, the kind way to say it is they have other priorities. That's the kind way to say it. The unkind way to say is, well, I don't know, they don't care about poor people. They don't lose any votes. What difference does it make? But I don't know. But the kind way to say it is they have other priorities. I mean, we used to hear week after week, David Cameron would get up in the House of Parliament and he would say that the way to spend more money on the NHS is to get a strong economy. So he just defended austerity as delivering a strong economy. And that way I could show what a nice, caring fellow I am and spend money on these social priorities. But it didn't work. It didn't work. As I showed you, incomes went down. It didn't work. So but the argument, whether he believed it or not, I don't know. The argument was, we can't do all these nice things to make poor people feel better because we can't afford it. But if we're strict, then we'll get the economy to grow and then we'll be able to be as nice as you like. Now, whether he believed any of that, I have no idea. But that was the argument. It was false. It was economically illiterate. But people seemed to believe it. So they justified austerity on the basis of, we've got an agenda for the whole of society. And you people who want to spend money on Sure Start and children's centers, you don't realize that's driving the economy into the ground. Well, we had a big change at the beginning of the pandemic. The same political party that said we have no choice but austerity said, whatever it takes, the spending, whatever it takes. That's a major change. Now, how much they believe it, how much that will continue, but they spent a fortune on the furlough scheme, which made a big difference. So we've got to marshal the evidence for people then to act on it, to influence the politicians. My argument has been that I personally don't want to sign up to one party or another. I'd like whichever party is in government to act on the evidence. If in practice that means a change of government, then fine. But whichever party is going to help deliver a fairer society is the one that I want to govern. And if we can't get action at national level, then let's get action at city level or regional level. So we're working with Greater Manchester. Coventry is a Marmot city. Gateshead has agreed on a set of Marmot principles. We've been working with Newcastle. We've been talking to other cities. Clacton by Sea, one of the deprived seaside communities. So if we can't get action at national level, let's talk to the politicians at local level. And my experience is that political party matters less at local level, because local politicians do have an understanding of real people's lives. They know what it means to have children with no opportunities. They know what it means to have housing problems and food problems, much more likely than national politicians to know that. So, as I've said before, I'm not hopeless about this. I think the evidence is important. And in my experience, if you can get in the same room as the politicians, they listen. Whether they want or are able to act on it is a different question. And it relates to the government strategy. It's got to be at different levels. Were we still part of the European community, I would say it had to be at transnational level. It's got to be at national level, regional, city, and community level. It's got to be at every level. And I've already touched on the last one of reasons for them not doing it. Somebody can tell me, and everyone will have a view, and I'm not expert on this. As I said, being kind, they might say they had other priorities. Now, there are legitimate political differences. I mean, so take the one of, are poor people responsible for their own ill health? Now, that's a point of view that we've all heard repeated many, 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 many times. My own view is we can settle that argument with the evidence. If people in the bottom 10% of household income had to spend 74% of their income to eat healthily, you can't blame them for eating unhealthily. I showed you the examples when I was showing you those photos of bedrooms of London, of employed people living in impossible housing conditions. Childhood poverty before housing costs in London was 17%, and after housing costs was 37%. It's not their fault that they can't afford housing. There's a housing shortage, and it's of terrible quality of what's available. So we can settle that argument. It's reasonable for somebody to raise, are poor people responsible for their own misfortune? And the evidence shows, by and large, they're not. It's circumstances. It's not their own poor choices.
Sure. Thanks a lot, Professor Sir Michael Marmot. There are many more questions, and I apologize for the participants. We weren't able to go through all of the questions, but I think that we are running out of time. And you've already dealt with many questions, which are very good and difficult. And I think the last comments you made about that we have to marshal the evidence and we have to communicate them very well to policymakers and be smart. So go local where needed. And I would say at the European Union level, things are changing. We are living clearly in a transition period. There's new leadership at WHO. So these are exciting times where change is possible. So I think these are very good words of you, Michael, to flag this further up. So I would like to bring it now to a close, and I would like to thank several people. First of all, I would like to thank the honor of Sir Roger Jowell, because without him we wouldn't have had this webinar, nor many of the other things that he left behind, which is an impressive legacy on which many people are building on. And then, of course, the keynote of the memorial lecture. So really a big thanks to you, Professor Sir Michael Marmot. It's delighted always to hear your talking. And then I would like to thank the organizers, and in particular Alison Park from the Economic and Social Research Council, Gerry Nicolaas and Guy Goodwin from the NatCen Social Research, Graham Farrant from the Social Research Association, and Rory Fitzgerald and Matthew Drew from City University of London. And of course, a big thanks to all of you out there sticking with us throughout the lecture and sending us so many questions. So thanks to you all, and well, I hope we'll meet again and have a nice evening. Thank you.